My name is Mark Portou. I'm a consultant vascular surgeon from the Royal Free Hospital in London. My particular clinical and research interest is in the treatment of CLTI and diabetic foot disease. I think the biggest problem with this group of patients is that they often present to us completely unscreened. They have comorbidities, extreme comorbidity, they have complex patterns of disease, and we really don't have the opportunity to medically optimize them beforehand. With the fairly comorbid populations, they're not all suitable for the open surgical technique, so tend to favor an endovascular approach in this population. So covered stents appear to have the most favorable outcomes. So covered stents are not without their issues. For instance, the covering of important branches, such as the internal iliac, often they require extension into the aorta itself and then for a stent on the other side, which can limit the options for future intervention. So I'm going to present for you the case of an 86-year-old lady. She presented through one of our emergency pathways, but with a history of classic symptoms of buttock claudication, thigh claudication, and then subsequent calf claudication. She cut a toenail a little bit too short and then presented to us with an infected toe and a toe-threatening infection. When we met her, she had an absent right femoral pulse. She then went to have a CT angiogram, which demonstrated that she had a calcified aortic bifurcation. There was a very focal right common iliac artery stenosis that was heavily calcified. It was our intention for her to be listed on the next available list. We were going to approach this under a local anaesthetic approach to the right common femoral artery with a retrograde crossing of the stenosis. I think up until recently, her option would have almost certainly needed a covered stent. But with the availability now of a novel technology in the form of the Shockwave L6 IVL catheter, which now comes in sizes up to 12 millimeters in diameter, we felt that given the very focal nature of this common iliac artery plaque, that this is almost a perfect lesion in the iliac for vessel preparation with the IVL technology. So access was through the right common femoral artery under ultrasound guidance. A guide wire was passed across the lesion and into the aorta. At this point, it was exchanged for an 018 guide wire and an 018 IVUS catheter was placed across. The justification for the use of the IVUS in this situation was for us to adequately determine the reference vessel diameter. From the CT, we were able to estimate it. However, we know from our experience of IVL in the past that oversizing the catheter appropriately leads to a better technical outcome. The reference vessel diameter we measured was 10.2 millimeters, which made the selection of the 12 millimeter Shockwave L6 IVL catheter the most appropriate. Having pre-dilated to 3 millimeters, I was then able to pass the Shockwave L6 catheter across the lesion without any issues. And it was then inflated to 2 atmospheres. We were reassured with the low inflation pressures associated with the L6 catheter because of where it is and the risks associated with rupture. So without any issues, we were able to deploy all 300 pulses in this area, and the inflation to 4 atmospheres is a technique that we're familiar with the M5 Plus catheter. Having delivered all 300 pulses across the lesion, we could actually witness as this progressed, the vessel compliance changing and balloon expansion improving as the cycles went on. Following deployment of the Shockwave L6, we were then able to assess the lumen gain using both a combination of angiography and the IVUS. We were intending perhaps to post-dilate, but having seen the impressive lumen gain on the IVUS, the lack of dissection and the lack of recoil, we're actually satisfied that the 12 millimeter Shockwave L6 catheter provided the definitive treatment, and there was actually no need to go on to stent or to post-dilate. Well, I'm delighted to say that having seen her in clinic at the 6-week mark, that far from us having to proceed to the toe amputation that we feared, she actually healed completely. And not just that, she's now enjoying completely pain-free walking with an unlimited exercise tolerance. I think this is the technology we've been waiting for, particularly when targeting larger vessels. So where those areas previously would have required stents, this is an option to avoid the need for stenting, which maintains future options. But even in those situations where stents are required, better preparation leading to better deployment of those stents. And this is really a game-changing technology in my opinion.